Good evening, everyone, and welcome to today's FACEMi India webinar on mental illness and addiction. I'm Ritu Sharma, the in charge of FACEMi Delhi Zone, Shanti Delhi. Before we move forward, I would like to introduce FACEMi to all. FACEMi India is founded by Dr. Nirmala Srinivasan. It is an advocacy group for mental illness in India. It operates as an informal group of families bound together by the common concern of wellness, safety, security, and dignity of our loved ones through WhatsApp. We at FaceMe advocate for wellness of persons with mental illness, that PMIs, for their rights with both central and state governments and other stakeholders. Expert guidance and the latest rules and regulations are imparted to family members actively through our monthly webinars and vibrant WhatsApp groups. We are deeply rooted in family ethos through an inclusive approach whereby we do not call family members as caregivers but family carers and PMIs as loved ones. Inclusive family is a salient feature of our group. We presently have 4 zones: Maitri Bangalore, Shanti Delhi, Shakti Kolkata, FAVMI Mumbai. Contact details will be displayed on the screen. Our topic for today is mental illness and addiction. Let us have a brief understanding of this topic. Mental illness and addiction are often interconnected, forming what is known as a dual diagnosis or co occurring disorders. Many people with mental health conditions turn to alcohol or drugs as a way to self medicate or get some type of relief from symptoms like anxiety, depression, etc. Substance abuse can also worsen mental health symptoms, leading to a vicious circle. Addiction itself can trigger or aggravate underlying mental health issues. Let us understand this more with the help of our esteemed speaker, Dr. Venkata Lakshmi Narasimha. Now, I would like to introduce Dr. Narasimha. So, Dr. Narasimha is an assistant professor at the Center of Addiction Medicine, NIMHANS, Bangalore. He has contributed to many publications and research projects, especially with World Health Organization and others. He is a recipient of the Best Researcher Award 2023. He has received many travel grants from World Psychiatric Associations. He has also received fellowship of Dr. Ramchandra N. Murthy Foundation, the Isam Nida Fellowship, and the Ineberia Fellowship. I would like to add a very important attribute of Dr. Nasimha, that is, he is one of the few doctors in our country who has an MD in addiction psychiatry, catering to this dual disorder diagnosis, which is very rare in this field. So now I would like to invite Dr. Nasimha to share his views and presentation. Welcome, Dr. Nasimha.
Thank you, madam. I don't have any presentation to share. I thought I will talk rather than sharing a presentation because of late I see that presentation becomes monotonous and it becomes the one-to-one interaction reduces with presentations. So,
yeah.
just a small disclaimer before I start. Whatever I'm going to present is based on my clinical experience, my reading, and so this does not reflect the views of the institute that I represent. So this is whatever, if there are good things that I say, it's on me. If there are not so good things I say, that's on me. That does not reflect the views of the institute. So this is the first disclaimer. With that, I start my presentation. If you see the definition of mental illness according to Mental Health Care Act, in that definition, we also have addiction as a mental illness. So addiction is also is a mental illness according to the definition. But for a long time, addiction and mental illness have been seen separately, and that leads to some extent reduction in stigma especially for people with addictive disorders when they come to the hospital and take treatment. But sometimes it becomes too categorical to separate these two conditions. But as you rightly pointed out, that when people with mental illness have these addictive disorders, that's when we call it as dual diagnosis. Why this has been important is we start with the prevalence. So if you look at the prevalence of this dual diagnosis, it's significantly high. Uh, how do we look at in terms of the data that is available across? Mostly, I'll be talking about the data that is there in the context of Indian population. So you know what are the addictions are. So there are two types of addictions. One is substance use disorders, which is alcohol, tobacco, cannabis, uh, methamphetamine, cocaine, opium. So these are the substances for which people can become addicted to. The other group are behavioral addictions, which is something which is in rise in the current scenario, especially after COVID. Gaming, gambling, and there is internet addiction that is coming up, although it is not recognized by WHO. Still, we see people having these problems with behaviors. Other form of addiction is the pornography addiction, sex addiction. So these are various kinds of behavioral addictions. When it comes to mental illness, we generally classify into severe mental illness and common mental illness. For severe mental illness, these are psychotic spectrum disorders like schizophrenia, schizoaffective disorder, and also the bipolar disorder. So, and major depressive disorder. These comes under severe mental illness, especially major depressive disorder with psychosis. When it comes to common mental disorders, these come again, depressive disorders, somewhere they classify as severe mental disorder when it is in the severe form of spectrum. But depression is also considered as a common mental disorder when it comes to mild severity. And there are conditions like dysthymia. So they come under common mental disorders. Among common mental disorders, there is anxiety disorders and substance use disorders. Among anxiety disorders, there are social anxiety, social phobia, and specific phobias. These are certain common mental disorders. After this classification, uh, so in MBBS or in when you talk about the common way how we present our answer sheets when we write exam, is we start with the epidemiology, that is the prevalence. Then we talk about the pathophysiology. Why these two conditions are related? The pathophysiology is why mental illness and addiction are related. Madam has told a very important point in terms of coping. So one of the hypotheses that we have is this self-medication hypothesis. For example, you take a person with schizophrenia. So a person with schizophrenia has positive symptoms, which is delusions and hallucinations. Sometimes also have negative symptoms, emotivation, anhedonia. They also have problems in their cognition, that is attention, uh, and also executive functioning. So with medication, the positive symptoms improve, but the negative and cognitive symptoms generally takes some time, sometimes improve, sometimes don't improve. In this context, what happens is people find substances as a way to handle these symptoms. For example, uh, tobacco use among people with schizophrenia is significantly high compared to general population rates. It's as high as 40 to 60%. Because what happens when people smoke tobacco is tobacco alleviates some of the negative symptoms, the emotivation that people report of. When they smoke tobacco, it actually gives a little bit of high. So, and it is commonly available. That's why the prevalence of tobacco use is higher among this population. Uh, Many people also use tobacco for improving attention. So there is, when people are disturbed by these hallucinations, it has been observed that people, when they smoke tobacco, for these conditions. For example, people with, so people develop schizophrenia because of the changes in the D2 receptor of our brain. And there are also other receptors that has been studied in development of schizophrenia. So people also develop addiction because of this D2 receptor, because D2 receptor dopamine is the reward reward neurotransmitter of our brain. So when there is a alterations in this dopamine receptors, that's when people develop addiction. So what has been observed is that people have common genetic predisposition to develop both schizophrenia, also develop addictive disorders. So the second hypothesis is there is a shared vulnerability between these two conditions. What is the third hypothesis? The third hypothesis is that one causing the other. Although earlier it was thought that, okay, people smoke cannabis, that's why they develop schizophrenia. People use methamphetamine, that's why they develop schizophrenia. But over time, what has been observed is the most common hypothesis is that people are genetically vulnerable to develop either schizophrenia or bipolar or psychiatric conditions. When they use these substances, that substances acts as a catalyst or a modulator, which brings out this schizophrenia. For example, among people who use cannabis, cannabis can bring forward schizophrenia by at least 3 years. These are all based on the longitudinal cohort studies, which has been done for 30 years, 40 years. What they have observed is when people use cannabis, the schizophrenia can come. For example, if I don't use cannabis, I'm about to develop schizophrenia at the age of 25. But when I use cannabis, the development of schizophrenia comes forward by at least 2, 3 years. So these are the three hypotheses. That one is a self-medication hypothesis. Second is common genetic predisposition hypothesis. Third is one causing the other hypothesis. But most commonly accepted, at least in the current scenario, is the first two. That is a common genetic predisposition. Second is self-medication hypothesis. So this is in terms of why these two conditions are, as Madam has told, that we call it as dual diagnosis, because most of the time the prevalence is somewhere around 30 to 40%, and alcohol and tobacco forms tobacco first, then alcohol, then cannabis, then other drugs. So this is about the epidemiology and also in terms of the pathophysiology. So let's come in terms of clinical scenarios. The most common clinical scenarios that we see among people who use alcohol. So let's start one by one. Among people who use alcohol, uh, alcohol per se don't cause psychosis, especially in most conditions. But some people who develop severe form of dependence, when they go through the withdrawal phase, that's when they experience a little bit of psychotic symptoms. So they experience hallucinations. So that is something that is seen during the withdrawal phase of alcohol. Uh, but what has been observed is that people who are vulnerable to develop major mental illness like schizophrenia and bipolar, when they use alcohol, like how I told about the self-medication, because alcohol also causes sleep disturbances, alcohol also interfere with a lot of other your day-to-day routines and other things. And alcohol also kind of, one second, just a second. Alcohol also kind kind of takes a little bit of a toll on your family relationships and your environmental factors. That's when alcohol becomes a trigger for development of these major mental illness, especially schizophrenia and bipolar. And alcohol also worsens the course of these two conditions. When it comes to common mental disorders, particularly anxiety disorders, you see a lot of people, the comorbidity of anxiety. If someone in this group has used alcohol or has seen people using alcohol, the comorbidity of anxiety, especially during the withdrawal phase, is significantly high. So, because alcohol is something which acts on the GABA receptors. So it's a GABA agonist. Alcohol is basically a GABA agonist, and most of our anxiety is something that is related to GABA. So because of that, alcohol is causes phobias, particularly social phobia. And some people with social phobia, especially when they wanted to talk on stage or when they have anxiety in terms of socialization, that's when they start indulging in alcohol. And then over a period of time, alcohol becomes a dependent kind of a thing. So that's about alcohol. When it comes to tobacco, again, we were recently having a meeting about implementing tobacco cessation services for people with schizophrenia. So one of the psychiatrists has actually told that we are fearful in terms of talking about tobacco to people with schizophrenia, The reason that the psychiatrist stated is that if we talk about treating tobacco, we are afraid that the patient might drop from follow-up. Why the patient might be dropping from follow-up? Because for that patient, it is the only high that they have in their lives. If I tell that I am going to take away this high, then that's where their compliance to treatment comes into the picture. That's where their interactions comes down. So this was one of the opinion. But the challenge with tobacco is, for example, patients with treatment-resistant schizophrenia, they're on clozapine. Tobacco reduces the level of clozapine, and the clozapine levels gets altered once they stop tobacco use. So it has a direct impact on the metabolism of the drug. So people with schizophrenia, treatment-resistant schizophrenia, when they are put on something like clozapine, psychiatrists have to go up on doses of clozapine high, but one, the effect will be there, but the side effects also might be there. So these are certain challenges with tobacco, especially because people use tobacco as a self-medication, and even for psychiatrists, the treatment of tobacco use among people with severe mental illness becomes a challenge. Then coming to the other commonly associated drug, that is cannabis. Cannabis per se can cause psychosis. For example, when people smoke cannabis one joint, they can experience something called as an intoxication psychosis. Till the cannabis is there in my blood, I can have certain psychotic symptoms like delusions and hallucinations. And once the cannabis goes out of my blood, then the psychotic symptoms might go off. This is called as intoxication psychosis. Second is cannabis-induced psychosis, where people use cannabis and they uh, experience psychosis for a prolonged period of time, which is somewhere around 1 month, once they stop cannabis also. But if they don't use cannabis later, the chance of they having psychosis is less. This is another group of population, but the number of people who transition after they have this cannabis-induced psychosis is somewhere around 40 to 50% actually transition to develop schizophrenia. So when someone comes with cannabis-induced psychosis, at least at the end of 1 year, 40 to 50% might go into an independent psychotic disorder like schizophrenia. The other challenge with cannabis is cannabis has two chemicals. Although there are 70, 80 chemicals, two main chemicals is one is THC, other one is CBD. So what happens with this THC and CBD is that THC is psychotic and it is also anxiogenic, whereas CBD is antipsychotic and it also reduces the anxiety. But what is happening with rampant increase in cannabis, the THC content has increased significantly over time. So because of this increased content of THC, what is happening is people not just developing psychosis, but also they are developing anxiety disorder. Especially in population where this bang use is common, although the THC content is not so high, many people come with reports of, especially after Holi, they come and tell that, sir, we are having panic attacks, please help us. Some people, these panic attacks continue for a longer period of time. Then coming on to other substances like methamphetamine and cocaine, again, which is increasing, especially in the metropolitan cities and also in the sea coast areas, also in northeastern areas, is the development of psychosis with this meth. I've been hearing, like, how many of you, I don't know, watched this Breaking Bad, where people used to manufacture methamphetamine, crystal meth in their what you call in the clandestine labs. In the same way, I have been hearing that at least in some parts of India, this kind of manufacturing is happening, and the kind of chemicals that are used to prepare this methamphetamine seems to be very dangerous. And people are not just having psychosis with this methamphetamine, but also having conditions like stroke, myocardial infarction when they snort this methamphetamine or when they smoke this methamphetamine. So that is another challenge with these drugs. Then coming to other common entity is use of this benzodiazepine, the sleeping pills, because most people with common mental disorders, particularly anxiety and depression, when they are given sleeping pills for when it comes to the sleeping pills, the problem with these sleeping pills is one is a therapeutic dose dependence. For example, many people we see that a psychiatrist or a physician has recommended a sleeping pill for example, there is a stress in the office. I met doctor, my BP was shooting up. And doctor told, okay, I know that you are anxious. Just take this sleeping pill for a week's time. But as soon as you take this sleeping pill for a week's time, you feel that, oh, it's feeling good. I'm feeling less stressful. Then people continue to use that sleeping pill for a prolonged period of time. So that becomes something called as a therapeutic dose dependence. So they continue to use at whatever the doctor has prescribed, but beyond the time that doctor has prescribed. Second problem with these sleeping pills is that when people start experiencing that it is helping, so then they start increasing the dose because people develop tolerance to the sleeping pill very quickly. So they don't stop at 0.5 mg. They go on increasing it to 2 mg, 3 mg. Today I was seeing an elderly patient in the OPD where the elderly patient has been using this sleeping pill for, so he was prescribed 0.5 mg of lorazepam, but he has increased to 6 mg. Now I wanted to reduce the 6 mg. He's 75. I wanted to reduce it by 5 mg. And then I asked him to reduce by to 4 mg. But by the time he comes after 20 days and tells that, doc, you told me to reduce to 4 mg, but I'm not able to tolerate. So the brain becomes dependent over a period of time. Although they wanted to stop, they find it difficult to stop. There are other things like painkillers, which are commonly tramadol, tapentadol. These are also, again, especially among people with anxiety disorders. This is something because anxiety also increases your pain. Once the pain increases, uh, when doctor prescribes you the painkiller, especially the opioid painkiller for relieving your pain for 5 days or 10 days, people tend to use this painkiller for a prolonged period of time. And people also tend to increase it in such a way that it becomes challenging for them to reduce this painkiller. I had an emergency physician who started the painkiller with uh, around uh, uh, around 50 mg of tramadol, and by the time she came to me, it was somewhere around 2000 mg of tramadol. So that was the level with which people have increased these medicines. Then the newer entity in this addiction is the behavioral addiction. So today I was in rounds. I was seeing one patient with schizophrenia for last 10 years. But the problem, and the schizophrenia has been controlled with clozapine 400 mg. The problem with which he has come to me because in the last 3 years, he started gambling. So he lost around somewhere around 1.5 crores, where his parents have to sell a property to help him to come out. But when we went back and looked into what actually made him to gamble, he's a very bright person. And what actually made him to gamble was that he was having significant negative symptoms. Because of these negative symptoms, he did not find any pleasure in any of the activities. And once he started indulging in this gambling, where he was getting a high because of the amount that he's investing and the profit that he's getting. So initial highs made him to get into it. But he continued like that. Although he's bright, although there is a component of skill and luck component is more, because of his cognitive deficits, because of schizophrenia, he was not able to focus for more than 5 minutes or 10 minutes in the game, and because of which he used to lose. So these two symptoms, both negative symptoms and cognitive symptoms, actually has made him to find gambling, and second, become dependent on gambling. Third, because in schizophrenia, you also know that there is something called as apathy, because you don't have, uh, again, this is very much variable across the populations. Apathy is that you don't get feelings to losses, you don't get feelings to emotions, you don't have emotions to various activities in your day-to-day routine. So even though there was a loss of 1.2 crores, he was not that emotional, but he started feeling guilty. Why I'm not emotional? So these are quite challenging scenarios, and off late, especially in people with major mental illness, the addiction to pornography, because one of the challenges that some people, at least in the severe form of the spectrum, uh, they find difficulty in getting into relationship, that relationship getting into marriage. So because of these challenges, because porn, access to porn has become easier, people are getting into pornography, but also getting into trouble because uh, in the communities, the pornography industry itself has been growing significantly. People are getting into challenges with getting into certain traps and getting into complications because of these traps. I have one patient who actually lost somewhere around 40 lakhs because the person whom he got into this pornography started blackmailing him because of the issue in that. And Then he has to approach police, which he was able to approach only after a period of losing around that much amount of money. So these are certain things in terms of the clinical course. Do we have adequate treatment? One of the challenges that people come and tell me is that people who treat schizophrenia or bipolar or depression generally don't treat addiction. People who treat addiction are not treating schizophrenia, bipolar. So where do we go? And this is not something that is challenging in India. This is something challenging across the world. And it is more challenging across the world compared to India. In India, I feel that things are better because as a part of psychiatry training, you are trained in both the things. But when you go to US, it is like you finish one, then go to one. But they are confused which one to treat first. At least in Indian context, at least in the context of the center that I work, we treat both together. But we prioritize which one to treat first and which one to treat next. For example, a person came with cannabis and psychosis. So we admit the patient and treat the psychosis comes down. Once the psychosis comes down, then we also intervene for his cannabis dependence. So we try to help them out with. So there are very good treatments that are available for both schizophrenia and substance use. But it becomes challenging because you are not dealing with one condition, you are dealing with two conditions. So you require, for example, the effort has to be double. And some people take it step by step. For example, when it comes to schizophrenia and tobacco, because tobacco causes physical harms. When it comes to psychological harms, it is less. So people try to treat the acute condition initially and then start working on tobacco. But when it comes to substances like alcohol and cannabis, because you know that if the person relapses on alcohol, the treatment for major mental illness that we are giving might go in uh, vain, because people forget to take medicines after they consume alcohol, or people overdose on medicines when they consume alcohol. So treatment becomes challenging, but there are very good treatments available in terms of managing the cravings, in terms of counseling methods, how we can work with the patients. Same is true for other substances. Like for other substances, there are not much of medication, but there are a lot of counseling techniques, especially when it comes to both behavioral addictions and also when it comes to other substances like cannabis, cocaine, and other drugs. Especially when it comes to opioids, there are very good medications that are available. I think most centers are trained enough to deliver these interventions. Uh, although although most literature talks that the prognosis is not so good, but with adequate treatment and adequate support, I am someone who believes in who is very optimistic in terms of the outcome. So with adequate treatment and adequate support, the outcomes are good, but you require patience, effort, and putting blocks together in a correct way. So with this, I think I will stop here. Maybe I think I have taken around 25 to 30 minutes. I'm sure that with questions, I might be able to clarify or bring in more examples from my experience. Thank you.
Sure, yeah. Thank you, sir, for providing this so much valid information which we never knew. So let us open the round for question answers. Can you mute everyone?
I'm just doing that.
You can ask your question on the chat. You can type them on the chat box so that it becomes easier to take up, you know. So,
To the first question, Meghna Rahani has asked us about tea and coffee addiction.
it's very
You'll have
important.
to unmute yourself because I muted everybody.
Okay.
Yeah,
So coffee is
sorry
a
about that.
stimulant. Yeah, no problem. So coffee is a stimulant. Coffee, again, there has been a lot of research to see whether coffee is addictive or not. So based on the research, if you consume more than 250 mg of caffeine in a day, that's when you start developing the addiction component, especially the physical withdrawal. Uh, in general, for example, uh, the drink that is Red Bull, it contains around 80 milligrams. So if you consume 3 Red Bulls, then you start having a lot of jitteriness or withdrawal symptoms. But most people, especially when it comes to people with mental illness, uh, one of the quoted reasons that they state that they consume coffee is to improve their attention span, because many mental health problems also comes with issues in attention. So that's where coffee becomes a self-medication kind of a thing. But again, research on coffee becoming an addictive is something that is less. But there is an ongoing research in terms of the what is the quantity and physical dependence that can happen with coffee.
Okay. What about the latest addictions on screen addiction and things like that? What is
Yeah, that's a great question. In terms of, again, as I told you, that the screen addiction is still in a very nascent stage in terms of the research overall per se. When it comes to people with severe mental illness or mental illness, that's research is very less. But again, especially in the context of adolescents and children, the screen addiction particularly is a major issue, uh, especially when people have these neurodevelopmental problems like ADHD. Uh, some there is some research to tell that as early exposure to screen between 0 to 5 years increases the impulsivity, like how when people consume alcohol, they become impulsive, they become aggressive. In the same way, when they watch excessive screen during this 0 to 5 years, that's where a lot of executive functioning, planning, decision making, ability to control impulses, all these things get impaired. And they are they when they grow into early childhood, adolescence, they get into a lot of behavioral issues because of early screen exposure. So that's why there is a lot of restrictions or guidelines in terms of not exposing the children, especially toddlers, young infants, and also the till adolescents, to be careful about the screen. So this is about the screen addiction in a nutshell.
Okay. So there is another question on porn addiction. The person has asked is, can this be stopped with natural methods? I do not understand the question, but you can read. It's there on the chat, sir.
Yeah, again, I understood that pornography is something has been studied for quite some time, but still it has not been qualified as an addictive disorder. But most people with pornography addiction, what we see is they have a comorbid condition. For example, I when I was doing therapy for some of the patients with pornography, one of the common things that I see is in terms of the social anxiety. So they have social anxiety, and they try to they didn't had friends through during their childhood, and as they grow, one of the easiest way to get high seems to be pornography. And so the ease, accessibility, and the quick reward that makes porn more addictive. But one of the ways to come out of that is, as someone was pointing out in the message, that to try natural methods. So to get, uh, again, it is individualistic, very individualistic in terms of how to come out of that. For example, the patient that I'm talking about, so he's married, he has a wife. So the interpersonal conflict between husband and wife and the separation between both of them, that was something that led to increase in pornography and issues in the marriage. When we work with the family and we work with the couples, that's when the problems between the couples started and their engagement became better. That's when the pornography has substance to other substance. He started with alcohol, then went on to cannabis, then went on to porn, then went on to sex with prostitutes, which he was spending 30,000, 40,000 per month because he has been spending a lot of money. Then once we addressed his addiction component, the potential, the reasons for his addiction and other things, that's when his pornography and the other aspects has come down. So again, it is individualized. For each individual, the approach seems to be different because there is a lot of comorbidity. For some, it is social anxiety. For some, it is impulsivity. For some, it is depression. So for some, it is the couple's issue. So it is different. That's how we approach it. Thanks for
Okay.
the question.
Yeah. Shreyas Rao has raised his hand. Shreyas, would you like
Uh,
to ask the question?
yeah, doctor, I am basically a lawyer and I deal with matrimonial issues.
Mm.
And furthermore, as far as I'm diagnosed with bipolar disorder, and I would not mince words and I would not be ashamed in mentioning that I myself have been grappling with the problem of promiscuity, and also promiscuity is one of them, womanizing is one of them, flings is one of them, and I have been taking recourse to therapy and all that, but my indulgences have reduced drastically. But then it sometimes so happens that when mania overpowers me, this thing runs amok and becomes unbridled. It could be anything. I'm not talking about extreme things like commercial sex or something. It could be visiting orchestra bars or something like that. So, uh, and when I've spoken to the psychiatrist, he says that yes, these are tendencies which happen with people with bipolar. So, for instance, hypersexuality and things like that. You need not be guilt-ridden. Therapy will rule it out because these are all common behavioral deviations. So, what would you suggest that therapy, along with effective medication, will arrest this and nip it in the bud?
Yeah. So as you rightly pointed out, sir, I completely understand what you are going through. Uh, Not completely, to some extent understand, because I don't know the a lot of other contexts. But whatever you have told, I got it. See, as you rightly told, that these are, for example, sexes are something natural. What happens in bipolar is that during mania, as you are telling, that the sexual drive increases significantly. Uh, Two things. One is that when this mania episode comes down, uh, over time we have seen that people with bipolar do have certain ups which doesn't get controlled completely with medicines, or when the bipolar prophylaxis is not adequate, that's when people tend to have small hypomanic kind of an episodes. So that's when people get into problems with, as you rightly told, in terms of the promiscuity, sexual high sexual drive for 2 3 days. Also, this is something that is also related to substance use. People, when they have these hypomanic episodes, they enjoy these episodes because sometimes they are also productive during that time. Sometimes also they indulge in substance use. Sometimes these behaviors can become problematic. So two ways to address, as you rightly told, that adequate prophylaxis. The prophylaxis to an extent that these kind of small ups or small ups for 3 days, 4 days don't happen. Second thing is there are very good therapies, as you rightly pointed out, in terms of understanding when these ups happen and how to address those ups. So there are some therapies. For example, many people come to me and tell that for 2 3 days their sleep is disturbed. That's when they get an up for 2 3 days, and that's when they get into problems. So working on those 2 3 days of ups. Some people come and tell, sir, one day if I consume alcohol for 2 3 days, my mood becomes very down, and that's when I wanted to do certain things. So both therapy and also uh, adjusting the prophylaxis to such an extent that these kind of ups can be prevented can be helpful. Again, as you rightly pointed out, that uh, again, to our experience, that it has to be individualized between person to person. So there is no one solution for this kind of issue. Thank you.
Sir, going back to the pornography question,
Mhm.
okay, there's one more question related to it, so I'm just continuing with that. What about a child addicted to pornography? How do you deal with a situation like that? I mean, is there
Again,
a difference in the way you handle an
yeah.
adult and a child or an adolescent?
Yeah, so again, it is all for especially for children. It is children and adolescents are people who has a strong emotional drive, but their prefrontal cortex, which is the brakes, are still not yet matured. So it takes around 20 to 25 years for your brakes to fully mature.
I
So
think
till the
the person wants to ask the question herself.
yeah,
So
please.
maybe it'll, whatever is the correct question, I think will come forth. I'm sorry to stop you, sir.
Go ahead.
Shivani, would you like to ask a
Yeah,
question?
hello. Yeah. Good evening, Dr. Narasimha. I'm Shivani here.
Hello, madam.
I am an educator by profession and I do counseling and therapies as well. So I have a student who's studying in class 7 and he is addicted to pornography. And when I took the case history, there's a trauma, childhood trauma that's there in child's life, the separation from father. So I would want to know from you, how do you help this child get rid of pornography and focus into the study part, like that's lagging behind?
Yeah. So
Yeah.
as you have rightly identified what is uh, most probable causating agent, because as I was telling that many of these conditions have a comorbid problem. In this case, it is trauma. And people who has trauma during childhood, we know that these are people who have problems in terms of regulating their emotions, have problems in terms of anxiety. So pornography becomes an easy way to handle some of these things. Because they have problems in terms of emotions, they find it difficult to get into relationships in the real world. So that's when they wanted to get into relationships in a virtual world. Nowadays, because of accessibility and availability, pornography becomes an easy thing. So addressing the primary concern, what is actually leading to this? So that becomes, when you understand what is causing this, and when you address that, that becomes easier to help them to come out of this. Uh, to our understanding, substance use or behavioral addictions is an epiphenomenon of underlying vulnerability. The underlying vulnerability is here in this case is trauma. So you relieve the trauma, you work with the trauma, you help him to navigate through this trauma. I'm sure the other part of it comes down to an extent.
Okay. Thank you. Thank you. Yeah.
So the next question is chewing nicotine to
Yeah,
control smoking. Is it harmful, or
yeah.
is that the
It's
way one should take it forward?
chewing nicotine gums is a way to take it forward to come out of it. There is a good amount of nicotine replacement therapy, chewing nicotine gums, lozenges, patches. Now there is a spray. There are at least 3, 4 FDA approved medicines to come out of this. But chewing tobacco, no, strict no. I'm keeping the answer crisp for the purpose of time.
Okay, sure. So the next question is, it's a long question. A person is having a bipolar disorder and dyscalculia that was diagnosed 10 years ago. It took more than 5 years to diagnose by the institutions named PGI Chandigarh and AIMS Delhi. The doctor prescribed him Valproate 500 twice a day, plus some more. He himself stopped other medicines, which may reduce smoking and drinking habits. Now he takes only Valproate 500 once a day. Regular smoking and drinking in the evening. He indulges into the business which takes this mental peace, money, and respect, but he never learns from his failures. He's becoming violent and the family members talk about his habits and behaviors. Please suggest what to do. Should family members leave him alone or tolerate his behavior? And why gets attracted to the family members who are unethical or destructive?
Why gets attracted to family members and friends who are unethical
Unethical or
and
destructive. It's a long question by
yeah,
gentleman. I do not know the name because
yeah,
the name is not correct.
right, got it. So again, 500 mg, if the person is diagnosed with bipolar, 500 mg may not be able to prevent his symptoms. So because the doctor has prescribed 1,000, understanding what is his requirement. So some of these symptoms could be the aggression, irritability could be manifestation of the bipolar per se. Uh, again, it goes on to the self-medication hypothesis, where people, uh, especially when they have these problems with mental illness, their association with the general population reduces significantly because general population is busy in terms of doing their own activities, and they're at the general population giving attention to people with mental illness also because of the stigma and other things reduces. But the easiest way to get attention is people who are a bit deviant in terms of people who use drugs, people who are not going for jobs, people who are so the deviant peer groups become an easiest way to link, and that's when they get into some of these behaviors. That is one of the hypotheses, but there are again a lot of other hypotheses. How to seek help is again it is a challenge for the caregiver, because especially in Indian context, uh, because there is no systems that are in place to help caregivers. How do you access help? Although they are on the papers, but to access help it becomes challenge. One of the things that we found helps is that once people stick onto the medicines and their symptoms comes down, that's when problems come down. So trying to go back to the healthcare system repeatedly, and trying to get things sorted, especially in the context of the psychiatric illness, will solve other problems. Uh, Again, I didn't understand the question related to dyscalculia, but there is some genetic predisposition for dyscalculia along with schizophrenia, because the genetic genes that actually regulate both of them to some extent are related. So that's what I can tell.
Okay.
Yeah.
Sir, this is a question from me. Family carers who have, with their loved ones with mental illness and addiction, they're always, it's a double-edged sword, they're always, worried, if they go back into addiction, the mental illness will get aggravated, or
Yeah.
they'll stop taking medications. Then, it's always a fight which family carers are going through.
Yeah.
Can you share some success stories where the dual diagnosis has actually worked, which will be an inspiration to a lot of families?
There are a lot of success stories. There are a lot of success stories in terms of suddenly it doesn't strike me, but for example, a person with uh, I had a patient whom I have been seeing from last uh, 10 years now, and first 3-4 years of admissions are secondary to cannabis use and flaring up of bipolar, and it took at least 3-4 years for us to establish a kind of a relationship where we told him, or to bring his cannabis use under control. So it was quite challenging, but now he has stopped his cannabis, and his bipolar symptoms are also better. And for the last 7 years, he has been doing very well. And he comes for regular follow-ups and does well. So like that, there are a lot of success stories. Suddenly, it doesn't strike me as you ask. Yeah, maybe after I answer 2-3 questions, if it comes to my mind, I'll let you. But one key, at least in my experience, that helps, especially people with dual diagnosis, is the therapeutic alliance that you form with the team, and also in terms of having a long-term association with a particular team helps them. For example, today I was talking to a person who had depressive disorder, and he came to me with gambling, and the gambling he lost. By the time he came in January, he lost somewhere around 4.5 crores out of 6 crores saving that he had. So he was left with 1.5 crores of money. So he came that, sir, I'm worried that no, his wife has brought him that she's worried that he will lose another 1.5 crores. Then I had started engaging him. Then I offered him to get admitted to counseling. Then he refused, but he came back second time, third time. So this time he got admitted. He's better now. One of the things that he told was that, Doc, one thing that I my motivation increased because the time that when you came, when my wife was asking me to admit, you did not admit. You gave me the opportunity to talk. You gave me opportunity to come back. In the 2 months, he lost 25 lakhs. That is secondary to him, according to him. But right now, when I came, I'm decided that I wanted to stop. I decided that I give my full dedication. That therapeutic alliance is something that is very important, especially when you wanted to bring out people from when they have this dual diagnosis. Again, to get that, at least in the Indian context, in terms of time, in terms of human resources, it's a quite challenging scenario.
Okay. Thank you,
Yeah.
Doctor. Anybody else would like to ask any question? You can raise your hand.
I
Yeah,
raised my hand.
Mr. Bajrang
Hello.
is also there.
Sir, I want to ask one question. Is there any link between schizophrenia and dementia? Suppose schizophrenia is in young age. In the old age, can he develop dementia, sir?
Again, to my knowledge, that risk is less, but the challenge is that people with schizophrenia, as time progresses, if the treatment is not provided adequately, they develop cognitive symptoms, which earlier people used to call schizophrenia as dementia precox, which means that schizophrenia has come very early. So the cognitive symptoms progresses to an extent that it looks like a dementia, but schizophrenia increasing the risk of dementia, again, I am not very sure.
I have a question. Can I ask?
Yeah,
Yes, sir.
Raman, go ahead.
Yes, see, basically, I have got a problem. Why is that people who have got bipolar, they are constantly in denial? How to meet this problem? Because I noticed that I was also in denial. My son, I mean, of course, he's been treated well and all fine, but constantly they don't believe that they have a bipolar or they don't agree to the diagnosis. What's the solution to this?
So that is true with more, it's a valid question. That is true with many other mental health conditions, because there is something called as an insight, which gets impaired, especially in people with mental illness, because mental illness insight is something that is part of your prefrontal cortex. It's one of the executive functioning, which gets impaired along with the mental illness that we are talking about. So once that insight gets impaired, especially in the acute stages, it is difficult to convince people that you have a particular condition. But what we have seen
in my case, there is, of course, I was in acute stage earlier. Now I'm doing very fine. And I don't think my son also in acute phase now. He's doing fine now. He's holding a job for last 3 years, a very good, respectable company and all. But then there's constant denial is there. I don't know how to solve this problem. Because he does not agree that he has got a problem.
Yeah. Again, there are ways in which how we can work on it. One of the ways is to there are various ways. One is to educate them. Second is to have one-on-one conversations with the psychiatrist. Third is we generally, again, it's all depends upon the conversations that psychiatrists have with people and try to explain them about various things. What I've seen is over time, people get a bit of understanding about their own health condition. That is something that I have seen. Although in the first episode or second episode, they don't realize, but as days progress, today only I was seeing one patient when he came in 2024, April, he absolutely told that I don't have bipolar. But he somehow we convinced him to take medicines. In January of this year, he stopped medicines. Following stopping medicines, he had a full-blown bipolar episode, which did not controlled with OPD-based management. He got admitted. He stayed for 40 days. During this 40 days, a lot of work has been done in terms of providing him access to materials. So now he came for follow-up. He's doing pretty well. But now he recognizes that he has a bipolar disorder because he spent some time reading about his own illness. He has seen in the ward there are a lot of people with bipolar illness. He's seen how they are improving. When he came to OPD, he saw a lot of other people who have this problem. So what makes people more insightful? It's again, it is different for each individual, but every attempt has to be made by the clinicians to educate people, make them kind of understand, collaborate with them, and help them. So this is my take.
Sir,
what about people who don't talk much? I mean, in my case, I have one more question to that, Saraswati. See, is that when I spoke to my psychiatrist, who is psychiatrist for my son also, she said it's a part of personality. He doesn't talk much. Does people who got mental illness, they don't talk much, or is it his personality itself?
Yeah, again, it is different between individuals. Some people are internalizers, they don't talk much. Some people are externalizers, they talk more. So it varies from individual to individual. Again, there are ways to address for people who don't talk much, they tend to read more. So they give them more IEC material to information material to read for themselves. So that's why we have a bunch of information materials. So if people don't want to talk more, we give them information material, read, come back to us and discuss more if you have any doubts. Generally, people tend to take some time, read with lot of. So these days, I don't discourage people from Googling. I tell that, see, boss, you have diagnosed with ADHD. Why don't you read Google and come back and discuss with me next time? So that works very well. People come back, read, and then they come up with, sir, I have this, I have that, I don't have this, I don't have that. And then it makes my life easier because I spend less time to educate them. Yeah, you have this. So people are very happy when we tell them, go back, read, and come back. So that's what I do.
Thank you, sir. Before, I know we have gone a little overboard on time. So last few words, sir, before we conclude the session.
Yeah. From my end?
Yeah, any last few words to us?
Yeah, one thing I'm very happy that FACEMi has been doing this. I think we need more such activities to make people educate themselves better, because there is a lot of misinformation going around, especially in the context of dual diagnosis, because it is a kind of a, what you call, as you have used, it's a double burden. And when there is a double burden, you need more support. I think some of these forums, I keep getting messages from Sachin, Dr. Sachin, that someone has posted in the group, this is a challenge. So sometimes I feel, although I'm in a busy OPD or something, maybe I take some time and try to respond, because this kind of brings in some kind of a support. I think what you have been doing is great. You should continue, you should grow big, and you should make more such activities, especially because uh, although people with mental illness has their own burden and their quality of life gets affected, the caregivers' quality of life, especially when they have mental illness, especially when they have two conditions, it is significantly, the burden is higher. So this groups makes, although we talk when we read textbooks and when we tell people find groups, we also need to have, we also need to be empowered that these are the groups that exist, these are the groups that you can go, where you get authentic information, not the information that is unscientific. So thank you. I think you have been doing a great job.
Yeah, thank you. Over to you, Rita.
Okay. So, yeah. So I would like to just conclude this session, and with all gratitude to Dr. Narasimha. Thank you so much, Doctor, for so much insight in the subject. We could understand the connection between this addiction and mental illness. It's so much connected, and how we can, you have really helped us with some good clues to overcome it. So we look forward to having more interactions with you in future for help to our family members and PMIs. So thank you so much once again for giving your precious time to us. Thank you.
Thank you, madam.
Yeah, and thanks to Saraswati, thanks to all the members, participants who have given their time, who have attended this session. I really thank all of you for this contribution. And of course, FACEMi, Dr. Nirmala Srinivasan, she has missed this session. She'll surely, she was saying, I will be, she really loves to be in such sessions. So thanks to her also for organizing the FACEMi webinars. So thank you all. And we will conclude this with our FACEMi pledge. So I request Saraswati to display the pledge on the screen so that all can read, and I'll just read it out. Yeah. We, the members of Families Alliance on Mental Illness, FACEMi, pledge to support one another and other families in similar situations, and use language which conveys love and respect towards each other, and especially towards PMIs. We shall strive to protect and promote the rights of PMI as enshrined in the laws of the land. On this day, we take this pledge to work towards the vision and mission of FACEMi India. Thank you. Thank you so much. Thank you all.
Thank you.
Yeah.
Thank you.